Good evening, everyone. A very warm welcome to all of you to our episode 6 of Artlines, the Voices of Cardiac Anesthesiologists, brought to you by Acta West Bengal. Today's session focuses on a critically important phase of cardiac anesthesia and intensive care, the post-op cardiac ICU, the first 6 hours that matter. These initial 6 hours often determine the tragedy or good news of recovery and the call for a vigilant monitoring, precise decision making, and timely interventions. So from hemodynamic stabilization and bleeding control to ventilatory strategies, renal perfusions, every step plays a pivotal role in shaping the outcomes. So we are privileged to have Dr. Arnav Shamanto is just recent passed out, one of the brilliant students from IPG Kolkata, here with us, who will present us and walk us through evidence-based practices. He will share the real-world experiences and help to decode the nuances of early post-operative care in cardiac surgery patients. So we hope this episode ignites a thoughtful reflections, sharpens the clinical acumen, and fosters the collaboration across all levels of cardiac anesthesia practice. Not only the cardiac anesthesia, but the cardiac surgeons, cardiac anesthesia, and perfusion, all sectors of cardiac sciences. So before we begin, we will take this opportunity to sincerely invite all our early career anesthesiologists, the postgraduates, postdoctorals, and fellows to join IACTA West Bengal Society, which is a vibrant academic community committed to growth, learning, excellence in cardiac anesthesia. So let us grow together, share knowledge, and make a meaningful impact in this evolving world. So thank you once again for being here. So let's dive into today's discussion and explore those crucial first 6 hours in critical care, cardiac ICU. Orno, up to you. Orno, are you there? Can you answer us? Orno, are you there? Will you answer us?
Is having some problem with, I think, this audio or something.
If it is there, you can send me the your presentation and I can.
It just message you something like that.
Okay. Audio is not audio, Ashana.
Hello.
Yes, you are audible.
Can you hear me now?
Yes, you are
Yes,
audible.
we can hear you.
Okay, sir, I'm just presenting in a moment.
Okay. Can I start?
Hello, am I audible, sir?
Yeah, you are audible and your screen is
And
visible. So you can start.
Okay, sir, I'm starting.
Oh,
Good evening, everyone, all my respected teachers and my dear colleagues and my juniors. My topic for today is post-operative cardiac ICU, the first 6 hours that matter. This is a very important topic, as we have all are working in the cardiac ICU after the post-op in the post-operative management, and we have to contribute some very important. We have to contribute from our experiences and also from the knowledge. So I'm starting my presentation by I will be covering the topics like routine history after shifting to the ICU, the physical examination, and assessment, routine investigations, temperature management, management of bleeding, hemodynamic management, and management of tamponade and diagnosis of tamponade. So, coming to the history, we have to after the patient is shifted to the ICU, we have to take the brief history about the patient background regarding what is the age of the patient, like, because most of the patient that we encounter in the ICU post CABG, these patients will be of the geriatric age group, so they have to be considered, and the management should be will be different as compared to other patients. So age is a very important factor, and also the sex of the individual is also important, because as we all know that female patients land up into more cardiac complications following cardiac surgery, and they have been shown to have more risk of complications like congestive cardiac failure and other complications and other atypical presentations also. So then the type of operation. The type of operation is important, because the if it is a CABG surgery, the management will be different as compared to the cardiac surgery.
We are not getting audio, I think. Dr. Arnab?
We are not getting audio, sir.
Uh,
No, sir. না 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 এটাই থাক এটাই থাকো একটাই কাজ থাকে।
is everybody getting audio and presentation?
No, audio and presentation not available.
Oh, I think there is some network issue.
Uh, I'm calling him. There is
Okay.
something.
Okay, please.
Yes.
Am I audible now?
Yes, you are audible now. Please share your screen again.
Ma'am, am I audible now?
Yes, yes, you are audible now. Please
Okay,
share
ma'am.
your screen again.
Okay, ma'am.
I think you should have repeat some of the slides.
Yes, sir. Yes, yes, ma'am. No problem, ma'am. Is my screen visible, ma'am?
Yes, now it is visible.
Okay, ma'am. Ma'am, from which slide should I start, ma'am, again?
From the second slide.
Okay, ma'am. This one, ma'am?
No,
This one.
now Dr. Ravi's screen is
Yeah,
showing.
next one.
We cannot see on our slides now.
And my slide is visible, ma'am?
No, your slides are not visible.
That I'm sharing. It's showing that I'm sharing.
Please share again. Please.
Okay, sir.
There was some issue from my end. Yeah, your screen is coming now. Yes.
This slide, sir.
Yes, yes.
I'll start from the beginning again, sir. Okay.
Okay, okay. Thank you.
So I'll go through the topic from routine history, physical examination and assessment, routine investigations, temperature management, management of bleeding, hemodynamic management, and management and detection of cardiac tamponade. So history is very important as the patient is shifted. Ma'am, am I audible?
Yes, you are audible and
Okay,
visible
ma'am.
too.
Okay, ma'am. So, as the patient is shifted to the ICU, we have to note down some history about the patient background. What is the like? What is the age of the patient? What is the sex of the patient? Because age and sex, all these have a bearing on the management of the patient. What is the type of operation is very important because the management of a CABG patient in the post-operative period is very different from a valve patient where a aortic valve has been implanted. For example, in a CABG case where lima has been done, we need to keep the pressures on slightly higher range. But for AVR patients, we have to keep the blood pressure for in a lower range. And also very important thing is that whether the surgery was elective or emergent or not. In case of emergency surgeries, the preoperative optimization of the patient is not done adequately usually. So there may be postoperative complication and a huge bearing on the management in the postoperative period. Then we have to understand what was the indication of the operation, what was the preoperative catheterization report like, what were the vessels involved. Ma'am, am I audible, ma'am?
You are audible, but
What's
your screen is again.
oh,
Yes, please. Yes, now
it's
are
okay, ma'am.
you
Now,
are.
no?
Yes, it's okay now. Okay, please
Okay,
continue.
ma'am. So, preoperative catheterization report. What were the vessels involved? What was the LVEF like? And what was the type of valvular pathology in the preoperative phase? Then, success of the operation, especially in CABG surgeries, whether revascularization was done completely or incompletely or not, and whether there was any difficulties during the operation, intraoperative period where the in case of off pump surgery whether there was any prolonged period of hypotension which may have a poor neurologic outcome, so these needs to be taken into account. Then the CPB and aortic cross clamp times are also very important because longer the duration of CPB or aortic cross clamp, it is associated with more myocardial depression in the postoperative period, and also there is an increased risk of coagulopathy and bleeding. So coming to the another other points like ease of separation from CPB, whether weaning from CPB could be done in the first attempt or not. If not so, then we need to understand that this myocardium, either there has been a problem with myocardial preservation or with revascularization, and then we have to put emphasis on these conditions that may alter the postoperative management or the course. So, what are the current inotropic requirements, vasopressors or antihypertensives as needed? What is if there was any need for cardiac pacing, whether a intra-aortic balloon pump was used, whether any ventricular assist device was used, whether inhaled nitric oxide was used or not. So these all have a bearing on the postoperative management. Now, significant bleeding. This is very important. Significant bleeding in the intraoperative period is important because, as we all know, bleeding begets bleeding. So, if there was a significant bleeding in the intraoperative period, then we can suspect that there might be a coagulopathy and there is an increased risk of bleeding in these patients. And other significant comorbidities will also have a bearing on the postoperative management, like COPD, asthma, diabetes, renal failure, hepatic failure, etc. The preoperative medications. Preoperative medications, mostly in case of emergency CABGs, as we all know that the patient may have received a loading dose of anticoagulants. So they have an increased risk of uh, uh, bleeding in the intraoperative as well as in the postoperative period. Also, patients receiving ACE inhibitors or ARBs are also at a higher risk of hypotension in the postoperative as well as in the intraoperative period. And routine history of allergy has to be taken. Now coming to the physical examination and assessment. So this is as cardiac anesthesiologists and ICU care professionals, we have to first ensure that after shifting the patient with the proper position of the endotracheal tube, and whether the patient has equal air entry or not bilaterally, we have to verify correct ventilator settings, and also we have to verify the patient's oxygen saturation is adequate or not. Then we have to check the ABG results as soon as they are available, and we have to check the initial hemodynamic readings like heart rate, blood pressure, and cardiac output, cardiac index, PCWP if a Swan-Ganz catheter has been inserted, and routine CVP. Then we also have to check for the patient's heart rhythm. This is very important. We have to verify the pacemaker settings if the patient is connected to one, and we have to examine the heart sounds. This is particularly important in patients who have undergone a mechanical valve implantation, and it gives us an idea about the functioning of the valve. Then another very important thing is that we have to check for the chest and mediastinal drainage. This is very important. We have to see the patency of the drains and also whether there is bleeding or not, or whether the bleeding is excessive or not. Then we have to check for the peripheral pulses. The, the peripheral pulses are especially important if a femoral arterial line is inserted and or an IABP is inserted. We also have to check for the pupillary reflexes, but a more comprehensive neurological examination should be performed once the patient starts to emerge from anesthesia. And routine examination of the abdomen is also important, and the Riles tube needs to be checked once the patient has been shifted to the ICU. So coming to routine investigations. So a baseline postoperative hemoglobin is very important in the further management of the patient. Coagulation parameters routinely sent are the platelet, PT, APTT, INR, and ACT as soon as the patient is shifted. Other point of care coagulation methods may be used if we suspect that there is high chance of if the bleeding is excessive, then we can give appropriate management to the patient. And as we all know that post CPB, a vigorous diuresis is very common in the first few hours after the operation. This can lead to a significant hypokalemia or hypomagnesemia. which increases the likelihood of post-operative dysrhythmias. Standing orders are in place to replace the electrolytes. So, tight glycemic control of 120 to 180 milligram per DL of glucose should be maintained in the post-operative period, in the perioperative period rather. So, by we can use either a insulin infusion or a sliding scale. Now, cardiac markers. Cardiac markers are not routinely sent, but it can be sent. But elevations of the cardiac markers like CPK, CPKMB, and troponins are non-specific. So they should be assessed as a part of overall clinical picture and including the hemodynamic status of the patient and the electrocardiogram. So now coming to the post-operative electrocardiogram. Post-operative electrocardiogram is another very important thing, especially in CABG surgeries. So, few changes are common in the post-operative period. They are new onset RBBB and shifts of axis are also common and usually benign. Diffuse non-specific STT changes are not very uncommon and may reflect a pericardial inflammation. So where do we actually need a 12 lead ECG? Especially if we are already monitoring a continuous ECG, but if we see that there is a ST elevation in two or more contiguous leads in the territory that was grafted, it may indicate graft failure and we have to document the ECG as well. And also, if ST elevation across anterior leads can represent a lima spasm if the lima was grafted in the LAD, so that needs to be informed to the surgeon and that needs to be taken care immediately. So these are very emergency scenarios. Now coming to chest X-ray. Chest X-ray, again, ideally, uh, we should see the endotracheal tube position and also verify the correct position of the Swan-Ganz catheter and check the positions of all other tubes and drains. And we also have to check for pulmonary complications like pneumothorax, lobar collapse, atelectasis, effusions, and pulmonary edema. Ma'am, am I audible?
Yes, you are audible. Please
Oh,
continue.
the slide is not changing, ma'am. There's some problem.
Yes, it's slides are changing.
Now coming to temperature management. Ma'am, I have covered up to this. So now I'm starting with temperature management. So as we all know, CPB is usually accompanied by hypothermia to less than usually 32 degrees Celsius for most of the cardiac surgeries. Patients are usually rewarmed to at least 34 degrees Celsius before transfer to the ICU. This diagram is from Kaplan, where we can see that there are four phases. The first phase signifies the controlled cooling on CPB. Phase 2 is the rewarming phase. And phase 3 is a very important after drop that occurs during the post CPB and ICU. So the cause of after drop is a redistribution of the heat to the peripheries and also heat loss to the environment, to the surroundings. So what happens during that period is that there is increase in SVR, there is decrease in cardiac output, which is maybe caused by bradycardia due to hypothermia. There is increase in oxygen consumption, decrease in carbon dioxide production, dysrhythmias, coagulopathy, shivering, and an increased risk of infection. So after that, what we have to do, we have to manage this hypothermia. So management of hypothermia actually starts from the intraoperative period, where during the rewarming phase, we can use nitroprusside, and the use of high pump flows have been associated with uniform rewarming and reduced after drop of 4 degrees Celsius to about 2 degrees Celsius. And temperature monitoring in the post-operative period is of paramount importance. And use of forced air warmer blankets, bear huggers has been implicated. Shivering occurs when the patient may be emerging from anesthesia, where we can use 20 to 25 milligram IV meperidine for adults. sedation and paralysis if the shivering is very severe and associated with any other complications. So now hypotension occurs during the rewarming phase. As the hypothermia resolves, it leads to peripheral vasodilatation. So what we can do is that we can start with a 500 ml bolus of lactated ringers, and normal saline is usually avoided because it may lead to hyperchloremic metabolic acidosis and worsen acute kidney injury. Hetastarch compounds should be avoided due to the risk of coagulopathy and renal dysfunction again. We can use packed cell transfusion if the hematocrit is low, that is less than 22%, and alpha adrenergic agents may be also helpful if there is any vasodilatation and hypotension during the rewarming phase. Now coming to the management of bleeding. Bleeding can be divided into two parts, medical bleeding and surgical bleeding. So most importantly, we have to rule out surgical bleeding because it may lead to an emergency and that has to be addressed by the surgical team. So how can we define a surgical bleeding? The persistent bleeding in the absence of a specific hemostatic defect. This is very important. That is, the coagulation parameters are normal and there is a bleeding. And its character is usually sudden onset of fresh, rapid bleeding, especially if associated with preceding sudden increase in blood pressure. This is very important. So we have to keep in mind that if the bleeding is fresh, and occasionally another very crude technique though, we can check the drain actually. If the temperature is warm in the drain, then we can be sure that this is a fresh bleeding. So that mostly can be, should be surgical. Then another thing is that repositioning of the patient may also cause drainage of pre-existing collected blood, which is darker in color. So that also has to be taken care, as it may cause a false alarm. It usually occurs when the patient is made upright, made recumbent before extubation. So there suddenly around 200 or 300 ml of collected blood comes to the drain and everybody is alerted. So it may lead to a false alarm. So we have to rule out this also. Now, if when do we go for a surgical re-exploration, that we are suspecting that this is a definite surgical bleed, usually these are the parameters that we can follow. Greater than 500 cc of bleeding in the first post-operative hour, or some centers consider it a bit less also. More than 400 cc per hour for 2 hours, or more than 300 cc per hour for 3 hours, or more than 200 cc per hour for 4 hours. These are the absolute indications that we have to go for a surgical re-exploration. Now coming to the etiology of medical bleeding. Patients are anticoagulated before and going on CPB, as we all know, with a large dose of heparin to maintain a ACT around more than 480. The heparin is obviously reversed by protamine, but occasionally the calculated dose of protamine may not be sufficient. So it may lead to a residual heparin effect. Another important thing is that it may also cause a heparin rebound phenomena, which can also occur several hours in the postoperative period also. So an ACT should be done as soon as the patient arrives in the ICU, and the normal values are mostly 100 to 120 seconds. Now, qualitative platelet defects and quantitative platelet defects are obviously occur in all patients with who have undergone CPB. Platelet function may be impaired for several reasons. Many of the patients are on antiplatelet agents preoperatively. CPB also leads to impaired platelet function, and longer the duration of CPB, greater is the impairment. The platelet numbers can decrease following CPB also, the quantitative defect due to hemodilution, destruction, aggregation, and hemodilution on CPB or consumption. Clotting factor deficits may occur if the patient had any preoperative hepatic disease. And fibrinolysis also occurs due to plasminogen activation during CPB. So now, how do we manage a medical bleed? So medical bleed, we first we have to control the temperature of the patient. We have to correct hypothermia. As we all recollect that hypothermia is a cause of coagulopathy. Then we have to control the blood pressure if it is elevated too much. And protamine doses can be given 25 to 50 milligram IV if ACT is elevated. But we have to note that an idiopathic protamine reaction may occur with any dose, even if the previous doses of protamine were well tolerated. In excess quantities protamine itself is also an anticoagulant. Now, DDAVP, though it is not routine, it may be used in patients who to improve platelet function who have uremia or von Willebrand's disease. So these are rare thing. Now coming to platelet transfusion, FFP, cryo, and antifibrinolytic agents. These can be guided by point of care techniques, but when the patient is bleeding significantly, it is very difficult to acquire these tests. So we must resort to an empiric shotgun therapy, and we can go for uh, an empiric transfusion strategy also. So platelet transfusion, usually 5 units for adult patients in the face of suspected or confirmed defects in platelet function or number. 5 units of platelets usually raise the platelet count by 25,000 to 50,000 and also provides clotting factors equivalent to 1 unit of FFP. In a patient who is bleeding significantly, the goal is to keep the platelet count greater than 1 lakh of functional platelets. So, and then coming to FFP. FFP normally 2 to 6 units for adult patients, with each unit having 200 to 250 ml. They in a bleeding patient, they return the PT-APTT close to normal with usually these amount of transfusions. Now, cryoprecipitate, it contains fibrinogen and factor 8. One unit is 20 to 25 cc and usually given pooled as 8 to 10 units for suspected or confirmed hypofibrinogenemia. This is again we can get by point of care techniques. Then antifibrinolytic agents, where we are suspecting that there is excess fibrinolysis, we can use epsilon aminocaproic acid, tranexamic acid, depending on the institution. Aprotinin is not routinely used, but currently they are using aprotinin in patients with severe bleeding. Now, another important thing is that the not very important. No, the studies are there to uh, second this opinion. Raising the head of the bed or increasing the level of PEEP on the ventilator can also be used. How does this help? The mechanism is that these therapies decrease the mediastinal venous pressure or increase the pleural and mediastinal pressure, thus stopping small venous bleeding. So again, definite studies are lacking. Then PRBC transfusion. The PRBC transfusion is of utmost importance to maintain the hemoglobin level high enough to maintain adequate oxygen delivery to the tissues. This is very important. So again, as I said before, the choice of therapy should be guided by hematologic laboratory parameters, but occasionally we cannot, but most of the time we cannot get this all these investigations done in such a short span of time. So we have to resort to an empiric therapy. Now, transfusion of packed cell. If the patient is actively bleeding with hemoglobin mass is not maintained in a steady state, that is, it is dropping significantly, then liver transfusion protocol should be used, and the site and the cause of bleeding needs to be ruled out. If the patient is not bleeding rapidly, then we can go for a more restrictive approach to transfusion. That is, we can see that if most cardiac surgical patients who are hemodynamically stable and are not actively bleeding and are following an otherwise uncomplicated postoperative course, tolerate hemoglobin as low as 7 gram per DL without problems. But this is not a hard and fast thing. This may be we can restrict the transfusion. So we all know the potential risk. I'm not going into this, but we have to understand what are the signs of inadequate oxygen delivery, where transfusion is actually required. If there is a low mixed venous oxygen saturation, a high lactate level, or clinical signs of organ dysfunction that cannot be attributed to other causes. So this is all about transfusion. Now coming to the hemodynamic management. As we all know, blood pressure is according to Ohm's law, the blood pressure is a product of the cardiac output and the systemic vascular resistance. And cardiac output is further a, a product of the heart rate and the stroke volume. The systemic vascular resistance for the stroke volume is dependent on the preload, afterload, and the contractility. So here, as we know, as we can see that heart rate and rhythm are important parameters for maintenance of the cardiac output. So here, if there is bradycardia, that needs to be addressed immediately with either a pacing or a chronotropic agent. And then if there is tachycardia, it needs to be immediately addressed with rate control drugs or antiarrhythmic drugs. Rhythm, if it is not normal sinus rhythm, we have to consider pacing or antiarrhythmics or cardioversion, whichever appropriate. Now, stroke volume. Stroke volume is actually the difference between the LV end diastolic volume and the LV end systolic volume. The LV end diastolic volume, if it is low, as we can see by echocardiography, then it suggests hypovolemia and requires immediate volume therapy. So if LV-EDV is high, then we have to suspect that there is hypervolemia and we have to consider diuretics, vasodilators, and if required, inotropes. If LV end systolic volume is high, then we have to look for heart failure, and then we have to start vasodilators, diuretics, and inotropes, obviously. And low LV end systolic volume, we suspect hypovolemia or vasodilatation, and there we have to give volume or vasoconstrictor, whichever appropriate. Now, how to assess the uh, fluid responsiveness in the immediate postoperative period? There are several hemodynamic parameters to guide fluid responsiveness in a cardiac surgical patient, but they should be interpreted in a clinical context, obviously. The clinical parameters include the heart rate, but it not always provides a true picture, as these patients may be on beta blockers and the heart rate increase may not be reflected. Blood pressure in a volume contracted patient may be high, probably due to use of vasopressors, and urine output is a good indicator, but when urine output drops, it is usually very late. So among the hemodynamic parameters, most commonly used is the CVP trend, and other good parameters in mechanically ventilated patients are stroke volume variation and pulse pressure variation. If a Swan-Ganz catheter has been inserted, we can get an indirect but good idea about the LV filling pressures. Another crude method is the passive leg raise, which is not followed routinely. It is actually quite similar to the practice of doing a Trendelenburg position in the during the intraoperative period. So echocardiographic parameters, IVC collapsibility may be seen in mechanically ventilated patients. Now coming to the management of hypovolemia. So choice of fluid is debatable, crystalloids versus colloids. Colloids like 5% human albumin and starch are associated with similar hemodynamic outcomes. Nearly 80% of the albumin is retained in the intravascular space, but if associated with capillary leak, it can be detrimental because it may lead to tissue edema and further accumulation of fluid in the third space. So this may be detrimental. Starch also has some complications and should be used with caution. We have to rule out coagulopathy or excessive bleeding or renal dysfunction before using such. Inotropes should never be used in hypovolemic patients. And also hypertrophied hearts of AS or hypertension requires slightly higher filling pressures. Now, management of hypervolemia. Hypervolemia, it is though not very common in the immediate postoperative period, but usually occurs as an eventuality and is commonly associated with heart failure. So the management is same. It is diuretics, vasodilators, and inotropes. Now, this is a simple algorithm where we can use. First, we have to assess the cardiac output or the cardiac output or the cardiac index by whichever parameter is used in the institute. If it is normal, then probably the cause is a low SVR state, which may be due to CPP-induced SIRS, protamine reaction, or transfusion reactions, or some other cause. So the first line drug is usually norepinephrine at starting doses of 2 to 5 mics per minute. It possesses both alpha and beta action. Hence, even though afterload is increased, it does not depress the myocardial contractility. This is very important. So this is the basic difference from phenylephrine and norepinephrine. Phenylephrine is a completely alpha agent where it causes vasoconstriction, and if the LV function is slightly poor, it may lead to significant depression of the myocardial contractility of the myocardium. But phenylephrine has its specific use case where 100 to 200 mics boluses may be used in case of sudden severe hypotension, not responding to fluid boluses, but being a pure alpha agonist, again, as I said, it may lead to sudden increase in afterload and reduced cardiac output. However, higher doses of NORAD may be associated with severe increases in afterload and reduced cardiac output also. It may cause spasm of the lima, mesenteric ischemia. So very high doses are not warranted. Then last line or an add-on therapy is vasopressin for resistant hypotension not responding to fluids nor adrenaline alone. So then if the cardiac output or the cardiac index is low, then we suspect a problem with pump function. That is the contractility issue. And the drug of choice is an inotrope. And the probable causes include a low preoperative ejection fraction. Maybe the patient had a low preoperative ejection fraction, a prolonged CVB time or a cross clamp time, and difficulty with myocardial protection in the intraoperative period, or it may be due to acute bypass graft occlusion. Then we have to corroborate with the ECG or a graft spasm, especially lima. Then we need to check for the ECG for ST elevation. So what are our choices? Dobutamine can be used. Dobutamine is a beta agonist, more in favor of beta 1 than beta 2. It increases contractility and heart rate. Beta 2 effect can sometimes cause decrease in SVR and blood pressure. But beta 1 effect can cause dysrhythmias also. So we start at a dose of 2.5 mics per kg per minute and then upward titrate up to 5 or maximum 10 microgram per kg per minute. Above that, it has higher propensity to cause arrhythmias. Then epinephrine. It is a both alpha and beta agonist and increases heart rate, cardiac output, and SVR. Generally, a second line inotrope, starting doses of 0.03 to 1 mics per kg per minute. Dopamine is currently not used very commonly. Some institutes only use it. It stimulates dopaminergic beta and alpha receptors in a dose-dependent fashion, and its inotropic effect predominates in the 5 to 10 microgram per kg per minute range. Then another very important drug, milrinone, which is a phosphodiesterase inhibitor, as we all know. And it how does it increase the contractility? It increases the calcium availability at the actin myosin complex, and thus increases the contractility. And beta receptor stimulation leads to increased cyclic AMP, we know. So this indirectly causes a increase in contractility. So it is started at doses of 0.375 to 0.75 microgram per kg per minute. But additional effects is it reduces the PVR and is helpful if associated with right ventricular failure. Now coming to the management of cardiac arrhythmias. This is again very important. The rate needs to be maintained or managed in the... Yes, sir. Hello. Am I audible, ma'am?
Yeah, Dr. Arnab, you're audible.
Okay, sir.
Continue,
Okay.
please. Please continue.
Okay, okay, sir. Okay. So is my screen visible, sir?
Yes, yes, you're visible.
So coming to the management of cardiac arrhythmia. So for management of any cardiac arrhythmia, first we have to correct all the electrolytes and magnesium. Magnesium may be used in an empiric dose also. So first we come to sinus bradycardia. So for sinus bradycardia, we all know we can use the atrial or AV sequential pacing, which is better as compared to ventricular pacing, which is routinely used in some centers. So catecholamine infusion also causes also helpful in sinus bradycardia. Then third degree heart block, again AV pacing or ventricular pacing can be used with catecholamine infusion. Sinus tachycardia, we have to address the cause, whether it is hypovolemia, anemia, we need to treat that, and then we should administer beta blockers. So other common arrhythmias include the atrial fibrillation, which is perhaps the most common arrhythmia that we encountered in our practice. So first we have to correct again, as I said, the potassium and magnesium, because the patients are having a vigorous diuresis in the first hours of the post of the ICU. So we some centers use an empiric dose of 2 gram magnesium sulfate, and then if it is not getting controlled, we can increase. We have to see whether if there is any hemodynamic instability or not. If there is hemodynamic instability, then we go for a cardioversion, synchronized cardioversion. And if rates are on the less than 100, but the patient is is hemodynamically stable, we can go for a oral beta blocker. If rates are high, but the hemodynamics are maintained, then we can go for a pharmacological rate control with metoprolol 5 milligram IV every 5 minutes up to 3 doses maximum. Other options include IV amiodarone. Amiodarone, as we all know, 150 milligram over 30 minutes, followed by infusion at the rate of 1 milligram per minute for 6 hours, followed by zero point 0.5 milligram per minute for 18 hours. Then we can continue 400 milligram orally. That is a chronic treatment again. So IV diltiazem is also an option where we can use 0.25 milligram per kg IV over 2 minutes, followed by another dose of 0.35 milligram per kg over 2 minutes after 15 minutes, followed by infusion of 1 to 15 milligram per hour if necessary. We have to note that concomitant IV beta blockers and calcium channel blockers should never be used, as they may lead to complete AV block. Then other management of atrial fibrillation includes dual site pacing, which is a technique where the leads are implanted in two places in the atria. Two atrial pacing leads are placed, one in the high right atrium and other in the coronary sinus ostium, to stimulate the atria from different locations. Then coming to atrial flutter, the management is quite similar to atrial fibrillation, but we can go for a rapid atrial pacing in these patients if there is atrial flutter. Then other arrhythmias, which are the paroxysmal supraventricular arrhythmia, where we can also use a overdrive, overdrive pacing or a rapid atrial pacing. So rapid atrial pacing is used for both reentrant atrial tachycardias and atrial flutter. The atria is usually paced at rates of 10% higher than the ongoing atrial rate, usually 350 to 400 per minute. Precautions: we have to keep a defibrillator in standby, as there is always a chance of ventricular arrhythmias. So other arrhythmias that we encounter commonly include the PVC, where we have to treat the electrolytes. Atrial overdrive pacing is rarely required, but it may be needed. Lidocaine or amiodarone may be used. And then we all know the management of ventricular tachycardia and ventricular fibrillation. I'm not going into the details of that. So now coming to cardiac tamponade, a diagnostic chameleon. So suspicion is the first step for detection of cardiac tamponade. So presentation of tamponade may range from inconspicuous fall in urine output, mild metabolic acidosis with moderately decreased blood pressure, to overtly symptomatic patients with severe hypotension, raised CVP, and decreases in urine output. The characteristic Beck's triad is not very common in practice, so a high degree of suspicion can only help diagnosing the condition where the patient has only mild symptoms. Hence, any decrease in drain output or increasing inotropic requirements, subtle fall in urine output should be sought as a clue to tamponade. So this is very important. So detection. Detection, we have to have a clinical suspicion which has to be corroborative with the echocardiographic findings. So we can do a bedside echo where we can see a echolucent fluid-filled space around the heart. And RV free wall diastolic collapse. This is a very specific sign for cardiac tamponade, and distended extrapericardial vena cava, which is not a good indicator because mostly the patient will be on ventilator. Our patients will be on ventilators. Then other parameters, we can look for the ECG. These are not very good in the clinical scenario, but just to complete, low QRS voltage, electrical alternance, PR segment depression, and sinus tachycardia may be there. So we can estimate the volume of the pericardial effusion. If the circumference is less than 1.5 centimeter, means the circumferential dimension is less than 1.5, it is less than 200 ml collection. And if it is more than 2.6 centimeters, then probably it is a more than 500 ml collection. But we have to remember that cardiac tamponade does not depend on the volume of the accumulation rather than the rate of accumulation. So this is very important. So this is an echo where we can. Is the echo playing, ma'am? Sir, is
Yes,
the
it is
echo
playing.
playing?
Yes,
Okay.
yes, playing. Good.
Yeah. So we can see that this subcostal view has been imaged here, and we can appreciate that echolucent shadow surrounding the heart with the RV being collapsed during diastole. So this is a very characteristic echo, but most likely in the post-operative period, we will never get such a good echo window. So it is very difficult sometimes to diagnose like this. And especially if there is a clot present, then it may be mistaken as an hypertrophied myocardial wall. So management of cardiac tamponade mostly is surgical re-exploration. So there is no much other option for our patients. So mostly these are my references, and I complete my presentation. Thank you for your patient listening. Thank you so much.
Thank you very much.
Thank you.
It's a very nice presentation. Hello.
Yes, ma'am.
Yes.
Hello.
Yes.
Continue, Dr.
Yes. So we get to learn just some of the there is some comments that uh, that we should actually check the Doppler, that is the bilateral lower limb Doppler, arterial Doppler after completion of the surgery for especially for the patients who are undergoing the endoscopic or minimal invasive or robotic cardiac surgeries. As the patients are being peripherally cannulated. So after peripheral cannulation, the patency of the both of the pedal pulses is utmost important. And another thing I need to mention that echocardiography is of utmost importance for volume assessment and for diagnosis the bleeding, and if it is a volume requirements or an inotropic requirements. So it is very important apart from the urine output and the CBP or PA pressure. So the echo is of very important thing. So you have not mentioned in the first some slides. So afterwards you have just mentioned for the tamponade part. Do you
Yes, ma'am.
think it is important?
Yes, ma'am. Definitely. For volume assessment, echocardiography is a very important tool for us. For mechanically ventilated patients, as I said, that IVC collapsibility can be done, and also transthoracic cardiac echo is also helpful because the decrease in the end systolic volume and end diastolic volume and the end systolic volume diameter and the volume, they can be calculated by echocardiography. So they are very important, ma'am, because they will guide us for the further management of the patient.
Yes.
Because if the LV end systolic volume is higher, then we will suspect that the patient maybe is having a failure, and then we need to start and we need to go up on the inotropic dose. Diuretics maybe need to be started, maybe infusions or bolus doses maybe, and vasodilators also, ma'am, to reduce the
And
cut.
also, if we suspect the ST changes,
Yes,
so
ma'am.
we have to always see the echo first. There might be new RWMS.
Yes, ma'am.
So there might be spasm of the newly grafted vessel or any sort of abnormality. So the new onset RWMA after surgery
Yes,
is of
yes,
utmost important.
yes, ma'am.
Any other anyone have some comments? Dipendu, do you want to say something about this topic?
Yeah, I guess post-op cardiac critical care in my case scenario. So there is no criteria as such which is written, but I guess in minimal invasive scenario, the amount of or rather the prediction of tamponade is much more earlier than when to restoration timing. Like what is a patient undergoing a CABG with sternotomy and a patient undergoing a CABG with mini thoracotomy. Both the scenarios are different. So there is no latest new guidelines have come up, but I think P is very important, eco. But just want to ask one thing on one
Yes, sir.
question.
Yes, sir.
As you mentioned, like how often you do you really get so much of time to assess the eco with so much of details
No, sir. It is
before
very
you choose
difficult,
for
sir.
the
So, yes, sir. That is why I could not, because I did not mention it in detail, sir. But yes, definitely it is of help, sir. But mostly the clinical parameters and everything, they guide us, the management. And even in the post-operative period, the echo window transthoracic especially is very poor, and transesophageal echocardiography is not always available in all the setups, sir. So it is a bit difficult to get a echo done, a good echo done.
so he is good. What I'm trying to say is, do you really you do all the measurements and before you may come to a conclusion which helps with a T
No,
guidance
that is
or
what I'm saying, sir. No, no, sir. I'm saying that mostly the clinical part and the corroboration, everything, the amount of bleeding or whatever is happening, it will guide us to the management. But if we have time to confirm and the patient is holding the hemodynamics, then we can go for a quick echo assessment, and then we can intervene, sir. But for tamponade, sir, if it is
yeah,
very
correct.
acute, then it becomes very difficult, sir. But we have to just open, and if we don't get anything, also, then we can always have the option to close. But if we can, the high clinical suspicion of a tamponade will only diagnose a tamponade, sir. So it is always not, we cannot get a echo done, sir, always in the post-operative period.
Another thing is regarding the hemoglobin level.
Yes, sir.
Most of the hemoglobin is mentioned according to the American or abroad standards. Indian standards, I don't think 22% or rather less than 8% is for Indian population. Do we really maintain that? I just want to ask the others. Do we really let
Yes,
it
yes,
drop down?
it's very scaring if it is less than 8.
I think it depends on patient to patient in Indian scenario, Indian population, and obviously male and female patients. Both age matters. Also above 75, less than 10, uh, and also underlying comorbidities like CKD, patients underlying prolonged steroid therapy or COPD, active smoker, and how much is the blood loss or sudden blood loss. So a lot of things do matter, but I don't think we have a particular value that we need to really look into it. We have to go by the baseline of the hemoglobin which we have taken the patient at the time of induction, and then we
That
look
is
into
very
it.
important.
Yes, sir.
Yes,
Yes,
this
sir.
is very important.
Drop from the
Mm.
baseline hemoglobin.
Yes, the baseline hemoglobin is of very importance.
Yes,
And
sir.
another question is there, the blood product transfusion and graft function.
Yes, ma'am.
I have not understood the questions.
Okay, ma'am.
Now, I
Will you please?
maybe people are thinking, do you really, if post PABG patients they have a problem, a bleeding issue, looks like medical, do you, what is your way out? Like, do you do some investigations and then use blood products,
Yes, sir.
or
The
you straight away
first
give FFPs on platelets?
Yes, sir. The usually, sir, when we are seeing that the field was oozy in the operating room, and that has been reported in the ICU, if the platelet and FFP could not be acquired by then in the intraoperative period, we can transfuse as an empiric, as I told. But at least we do an ACT. We should do an ACT, sir. If the ACT is on the higher side, then we can at least give an additional dose of protamine. But occasionally, sir, what I have seen is that when we are giving FFP actually leads to further bleeding occasionally because some residual heparin, if it is left and FFP is transfused, after that post FFP, I have seen few cases. I have seen that they have started. But they were not oozy. This is in the intraoperative period. They were not oozy, but they have started becoming oozy after FFP transfusion in the post operative. This is especially in case of off pump. I am saying, sir, not CPV. So that thing is important, but ACT at least we can get it done. Uh, it will not take much time, and accordingly we can get a idea about that. But point of care measurements, they are difficult to get in all the setups, sir. And so an empiric therapy is probably what we should go for.
Yeah, I guess what do we do practice is if most of the patients nowadays you won't
Yes,
get ideally clinically ideal scenario.
yes,
Most
sir.
of them come with antiplatelets which are just stopped 3 to 5 days before surgery, the long acting ones.
Yes,
Picospin
sir.
anyway, we stop
Uh,
within 24 hours.
uh,
But most of our patients do have platelet count less than 1.5 and between 80 to 1.5.
yes, sir.
Now, if the patients bleed post-operatively or when the surgeons are closing, they say that the patients are wheezy. Do you give platelets or you prefer some other products? Post CABG, isolated CABG.
On pump, sir, or off pump?
It's an off pump.
Off pumps are actually what I have seen. There are differing opinions among surgeons, sir. So some surgeons feel that with FFP there may be graft dysfunction, graft blockage may occur. So what they suggest is that they try to avoid. They only correct with protamine and antifibrinolytics, and also some go against antifibrinolytic also. So this is one thing, but mostly. I have seen platelets FFP for off pump and both on pump also. Transfusion does not cause severe graft dysfunction or any blockage or thrombosis. So it
Oh
can
no.
be given, sir. So if the CABG was done on CPV, then platelet transfusion is routine in some centers, sir. So platelet there.
Arnab, I have one question.
Yes, ma'am. Please.
Actually, I want to know how FFP will cause graft blockage.
Yes, ma'am.
What is
Because
the
we are
mechanism behind it? What may be the mechanism behind it? And you are giving antifibrinolytics, and
yes,
we do not give after CABG is complete
yes,
over
ma'am. Yes, ma'am.
because of fear of graft blockage. So
Graft.
how FFP will do that? What is the mechanism behind it?
Ma'am, FFP will be supplying coagulation factors. So, in case of off pump CABG, it is a prothrombotic state already. So, after FFP transfusion, there may be a increased chance of this graft thrombosis and graft blockage, ma'am.
So this is for off pump CABG, not for on pump.
No, ma'am. On pump, ma'am. Again, that is what I'm saying. Platelet transfusion may be more. This means more
Hazardous.
suitable, ma'am, for because post
More
CBV platelet
suitable. Platelet
dysfunction.
after on pump CBG, platelet will be more suitable, not the FFP.
Yes, ma'am. Yes, ma'am. That is what I'm saying.
Mm.
But
Mhm.
in case of on pump,
Have
ma'am,
you got any reference regarding this? You got some reference, or this is surgeon's protocol?
no, this is mostly surgeon's protocol. What I'm saying, ma'am, because I
But
have
you did
not.
not find any. You did
I
not find
yes,
any reference.
no, ma'am. I also could not find
Okay.
it. This is
Then
what I.
we have to find it, na? If there is
Yes,
any reference.
I'll
Yeah.
look for it, ma'am. Surely.
Oh, oh, thank you.
Thank you, ma'am. Welcome, ma'am. Ma'am, I think there is another question. Will blood products have any implication on graft patency? This is what we are discussing actually. So graft patent blood products. Is it judicious to wean patient before 6 hours? Yes, why not? We can do that. We can wean patients before 6 hours. If the intraoperative period was smooth and we are not suspecting a large amount of bleeding, that is the only thing in stable post cardiac surgical patients we are concerned about only bleeding. So if there is no bleeding and the patient the intraoperative period was very smooth, then we can go for a early extubation within 6 hours. And transfusions on graft patency, it is I did not find any exact paper where they are saying or refuting this argument, but I have seen several surgeons not use any FFP or platelet for off pump CABG. Off
Yeah,
pump CABG.
obviously, if a patient is not bleeding, then there is no point of transfusing.
Yes, sir, definitely.
If there is a
If there is
need
a
of transfusion, the patient is bleeding, hemoglobin is low, so we
no,
have to give
there is
it
no role of
judicious.
routine
There
FFP
should be no
platelet transfusion. There
routine
is no role.
transfusion.
Yes, sir, definitely.
Yeah, you're right. And one more thing I want to add, just during shifting, many times patient becomes hemodynamic unstable.
Yes, sir.
Uh, at that time, it's difficult to diagnose whether it is tension pneumothorax or cardiac tamponade. Suppose patient was bleeding and they have tried to settle this bleeding, but somehow they closed that patient is now okay. So, but still it's coming in drain, heart is dilated. So many times small amount of bleeding
Yes,
during
sir.
shifting time when the drains are clamped. At that time, chances of developing tamponade is there. Though it's
Yes.
less chance, but if the shifting distance is more, then the many
Yes.
times it happens.
Pneumothorax also, sir. If
A
there is any
pneumothorax
incidental
also happens.
pneumothorax also, sir. During this period is
So
very
at that
important, sir.
time,
Yes, sir.
when the clamps are there, but when
Yes.
the drains are there, but it's clamped
It's
while.
clamped. Yes, sir. During shifting.
So at that time, just releasing the clamp, if improves the hemodynamics,
Yes,
then
sir.
most probably it is uh,
Control.
tension pneumothorax
Yes,
or
sir.
this one also. So that happens many times. So we need to be careful. Okay, thank you, Arnab, for
Okay.
nice
Thank you so much, sir. Thank you so much.
elaborate discussion.
Thank you, everyone, for your patient listening.
Thank you. And as we conclude, uh, we warmly encourage all of you, especially our young colleagues, to become a part of IACTA West Bengal. So together, let us build a stronger, more connected academic family, which promotes excellence, mentorship, and continuous learning of cardiac anesthesia. So please join us in IACTA West Bengal Society. Be a member. So stay connected. We'll look forward the next class that will be on cardiopulmonary bypass. What are the role of cardiac anesthesiologist apart from having a coffee? So this will be an interesting class. So stay connected, stay inspired, and always listen to the heart. So thank you very much for